Welcome to District 216, the intersection of art, music, cannabis, consciousness, and psychedelics. My name is Cole Lupoli. I'm the interviewer here at the District House. Today, we are very fortunate to have a guy making moves in a very novel way in the psychedelic space, in the neuroscience space, in the chiropractic space. He's a chiropractic neurologist who specializes in complex cases and brain optimization. Can we please give a warm round of applause to Dr. Joseph P. Smith? Well, first off, thank you so much for coming. You're one of the first neuroscientists and chiropractors, that's for sure.
Pleasure to be here. Thank you.
So can we just start off with how you got into the field of medicine and, were you always interested in helping people or what was the evolution of your track?
Yeah, when I was a kid, I kind of had a rough go of it with my family. And so I wanted to help other kids process that information. I was going to be a school psychologist. And unfortunately, my mentor committed suicide when I was in college. And so I'm like, I don't know what I want to do anymore. And my roommate's dad at the time was a chiropractor. So I thought, okay, I'll try to help people get back out of pain and get back on the field if they're athletes. And I got into that and kind of fell in love with the vitalistic philosophy of that. But at the end of that, when I was an intern, I saw some really cool stuff in terms of what looked like chiropractic miracles. But then I just saw a lot of people that weren't responding to that. They'd seen a lot of chiropractors, they'd seen acupuncturists, they'd seen traditional doctors that were doing pain medicine with them, and they'd seen occupational therapists. And there's just a lot of people that were slipping through the cracks. And I kind of decided at that point, I couldn't just be a chiropractor. I wanted to try to help that group of people that wasn't finding answers. So I just started researching how to help the people that weren't finding answers in the alternative or the standard model. That's how I got into it.
And so chiropractic neurologist versus a standard neurologist, what is the distinction?
Yeah, so just like in medicine and chiropractic, there's specialty fields. So in medicine, there's neurology. Neurologists are really focused on the brain, obviously, and the peripheral nerves, but they're more from a disease point of view. So if you go see a neurologist, they're going to do tests. If you fail those tests, they're probably going to order an MRI, and then they're going to diagnose a condition like Parkinson's or MS or dementia based on that MRI and some questionnaires. And then there's like a drug or a surgery or maybe radiation that might be useful if you have cancer that's affecting your neuro exam. And it's really awesome to go to a neurologist and get a diagnosis if you have a disease process. But a lot of people go to neurologists and they're basically told that their symptoms don't meet the diagnostic criteria of a disease. So they have memory issues, but they don't have dementia. They have a tremor, but they don't have Parkinson's. They have numbness and tingling or bladder issues or pain, but they don't have MS. And they're basically told there's nothing we can do, or maybe you're just depressed, go to psychiatry, which is a common thing. So chiropractic neurology, there's more of a emphasis on understanding how to bridge the gap between, hey, I feel great and I have dementia. There's exam findings that can show up decades ahead of the actual diagnosis of dementia that are connected with research, and we can identify those things and help people deal with them ahead of the actual diagnosis of dementia so maybe they never get there. And then also, I see a lot of people with concussions. So many people had a concussion early in life, and it's just ravaging them later in life, especially in the world of COVID. People are particularly having a hard time with COVID. A lot of them had a head trauma, and they're reconcussing themselves with the infection. And so the idea is instead of waiting until a disease process manifests, we can catch things when they're having symptoms but not meeting the criteria for a disease, and we can rehab them out of it, basically by doing like brain boot camp for that area.
And I looked into your acronyms because I think you had the most acronyms of anyone we've worked with so far.
Yeah.
I don't know if you saw the page. I had to Google them. For the people that didn't Google them, will you just tell me what those acronyms mean? Because specifically kinesiology came up.
Yeah.
I'm wondering how that fits into the matrix of chiropractic and neurology.
So in chiropractic, instead of getting like you're called a cardiologist or an endocrinologist, you might have what's called a diplomat. And so one of my diplomates is in kinesiology. And kinesiology is the study of movement. And so as a chiropractor, I was like, okay, I make this adjustment and then they walk to the car and it comes back by the time they get to the car. Why is that? Well, the muscles that were attached to those bones, once they activated those muscles with walking, weren't working right. And this pulley system caused that misalignment to come right back. So applied kinesiology is a diagnostic value system where I can use muscle testing to determine where is the problem that's causing this misalignment. But it's also connected to things like Chinese medicine, craniosacral therapy, meridian therapy, and other modalities. So the idea is you diagnose where the problem is, and then once you find the right modality, the muscle turns on, and then you know that's the right thing. So how do you know whether to do an adjustment, whether to do an eye movement, whether to do nutrition, whether to do a meridian, whether to do craniosacral? It's like these are all options that people can go to, but you can actually have precision with an exam what's going to work. And AK is one part of the foundation of my exam.
And so there's
like kinesiology.
And so there's a bioenergetic component to this. I mean, muscle testing. Raise your hand if you're familiar with muscle testing.
Yeah, muscle testing is very, very well understood, and a lot of people are using that. And so this organization, George Goodhart was the guy who took, Dr. George Goodhart, he took kinesiology and then added applied kinesiology to it. So the idea is it's a diagnostic value system, and it's really, really cool. But the bioenergetics of that is you have to have a really pure intention when you're doing it, because your intention can totally affect the muscle test, which is why I don't rely on just applied kinesiology anymore. I used to. That was my first foray outside of traditional chiropractic. But as I got into the brain and other neurological findings, I expanded my exam to include those things.
And so the muscle testing that I'm familiar with involves asking the patient certain questions. Is that correct?
Yes, you can do that.
And so are you tapping into some element of the subconscious potentially when you're exploring these various modalities with this verbal questioning?
So that's the type of muscle testing that's not what applied kinesiology is. So that's an application of muscle testing. And that type of muscle testing is almost a form of divining, where people will use pendulums. That's not exactly what I do, but that is an application for muscle testing. But yeah, you can ask questions all like power versus force. There's a book about that where he talks about levels of consciousness and using muscle testing in that way. And it's extremely useful, but also it can be extremely unreliable. So I would caution folks that they're relying on a muscle test. There's other things that you want to correlate that with. I wouldn't just strictly go muscle testing and then using that as your only answer.
So it seems like you've compiled quite a smorgasbord almost of these various modalities, and the East meets West. How did that evolve into the Atlas Health method and brain optimization more specifically?
I think failure. I wasn't getting results that I wanted. And so people would ask me, well, can you help me? And I'm like, well, let me just figure that out. I think that's part of the doctor's job, is to say, hey, I don't know. Let me go look and see what I can figure out. And so the Atlas method is something I've just coined what I do, which is basically Atlas is a book of maps. And so where are you? Where do you want to go? How are we going to get there? What have you tried? What worked? What didn't work? Why didn't it work? And then what modalities are available to us to help you do that? And the thing is there's all these different awesome fields out there that are focused on one modality. And if you happen to walk into that place when you need that one modality, or it covers enough of your bases, you have this awesome experience. But there's another way of evaluating somebody ahead of doing anything to figure out what to do and when and for how long, and coordinate a care plan so that you can walk them to recovery in more of a transformative experience than just treating symptoms. There's this idea about green medicine. Green medicine is not the same thing as a holistic model. Green medicine is to say, let's say I went to a doctor and I had acid reflux, and they're like, here, take this Prilosec to stop acid production. That's standard medicine. Green medicine would be, well, I go to an acupuncturist, they're like, well, you don't actually have too much stomach acid, you have not enough stomach acid, so take this hydrochloric acid, and it's better because it's holistic. And it might be better for that person, but it's not really holistic medicine. It's green medicine. It's still treating the condition. The Atlas method, in my opinion, is more doing a deep investigation to find the underlying cause. Hey, let's investigate this. Is it emotional? Is it physical? Is it neurological? Is it hormonal? Is it immunological? Is it metabolic? Is it all of these things? And which of these is at the head of the table? And then let's line up a care plan to get you where you want to go more judiciously and with precision, rather than just try something, hope that it works, and then it validates what I do.
Would you be able to give an example of some of these little causes that can lead up to larger problems?
An attachment disorder. A person has a maladaptive attachment disorder where they're stuck in hypervigilance, and let's say they get into a new relationship and they have a dismissive attachment style, and it's just stressful having that person in their space. That stress chemistry can cause, stomach issues, IBS. It can cause numbness and tingling. It can cause depression and anxiety. And so understanding how that attachment issue led to the development of their brain into hypervigilance can actually help them find the help that they need to recover, rather than just give them something to numb the depression or the anxiety.
And so if you were working with them, how would you come to establish the fact that they did have an attachment style that potentially was causing these underlying issues? I mean, is that part of sort of this full spectrum approach that you've adopted?
It's a history. Yeah, it's all in the history. Like if you listen to people, they will tell you exactly what's going on. Hey, when did this start? Oh, I started it right when I started this new relationship. And like, okay. And so then I might have them at that point fill out a attachment style questionnaire. Okay. Now that doesn't mean that they necessarily need to go see a therapist for that right now. Okay. But it means that it becomes part of the dialogue of their recovery. Let's say you go into therapy and you're anemic, you have Hashimoto's thyroiditis, and you have a massive blood sugar issue, and your brain literally is boiling inside its skull. That therapy might be useful to activate networks in your brain to help you come to a new understanding. But if you biologically cannot have a plastic change in your brain because of these other issues, it's not going to work. So rather than just say, okay, you have an attachment style issue, you need to see an attachment therapist, it's like, well, that might be part of your recovery program. Let's make sure that you have the biological, metabolic, hormonal, immunologic, neurological capacity to actually respond to that modality, and then have you go do that. But on the way to doing that, if we deal with the Hashimoto's thyroiditis, so we deal with the anemia, we deal with the chronic Epstein-Barr infection or whatever it is, they may get such a return to their quality of life and their stress chemistry could come down that the attachment issue no longer is ravaging them. So it's not like you have to do all of it, but just get an understanding of where things are so that if it doesn't work out the way that you want it to, you kind of know where to go next.
And what I hear you talking about is essentially someone comes to you with a problem, and a lot of traditional medicine seems to be in that disease treatment model. How is yours different, and in what ways do you say work with someone that goes, I just want to live a lot longer, I want to live a healthier life, and what goes into that type of analysis versus I have a problem, I have to fix it?
It's the same analysis. So rather than focusing on a condition and a disease process, I focus on physiology and optimization. So if I see somebody with a disease process happening, I can't treat the disease. I'm not a medical doctor, but I can work with factors that influence their return to health. It's a totally different concept. Return to health instead of treat disease. So if you are relatively healthy and you have a family history of, say, dementia, and I do a smell test with you, and you're like way lower smell on your left side, and you can identify what that smell is, you're already having sleep-wake issues and like messing people's names up, and you're in your 20s, it doesn't just go away. Okay. And then you can do things like eye movements. And so everybody, if you just kind of look at this thumb and then look at that thumb, how quick you respond to that, it's called saccadic latency. So if I go like this and then look at the one I wiggle, and then you look and it takes a while, I actually have software that quantifies that. So if your saccadic latency is over like 235, there might be already an issue in something called your frontal eye field, which is right next to the first part of the brain that starts to go south in different types of dementia. So if we see that in your 20s, and then I do some brain exercises with you, and then you no longer have a saccadic latency, that factor is now off the board. It's pretty cool. So the same idea is you just do your history, you get an idea what their goals are, then you do an exam and go, this is where you are in reference to where you want to be. These are the areas you're vulnerable. You actually have a fasting glucose of 124, which is not technically diabetes. That's 127, but it's going to ravage your entire body. So let's work with your diet. It's not always brain stuff, right? So when I'm working with people I want to optimize, which unfortunately right now isn't the majority of my practice. The majority of my practice are people that have problems, that are wanting a solution. When I work with those people that want to optimize, it's super fun because they're like super into it. And it's like, okay, that makes sense. And then when the diagnostics change and their exam changes and it correlates with their change in their quality of life, where now they go to like a classic scenario where they're no longer transposing numbers on their ATM, or they're no longer like having sleep-wake issues, then we can say, those symptoms that correlate early on with a condition that is the full manifestation of Alzheimer's later in life are no longer on the board. Your sense of smell is normal. You can identify it. You're sleeping better. You're not having saccadic latencies. Look, you can't prove prevention, but you can actually prove that they no longer have the criteria that is used to diagnose the condition. It's just a matter of semantics, but it's really what's happening. It's super cool.
And with these types of developments, can you actually change your genetics such that certain pre-existing conditions potentially are not just minimized, but that actual genetic code can be transformed with the proper protocols?
Well, that's a really interesting question. So you can't change your DNA necessarily, but you can change what part of your DNA you utilize. So DNA is really cool, right? So like epigenetic activation of DNA. So like, let's say like I roll up this sleeve, I'm not sleeping, I have celiac, right? So if I'm eating too much gluten or eating gluten at all, let's say I'm drinking like sugary drinks and like I'm fighting with my business partner, okay, my sleeve of like stress activation inflammation is going to go up as a survival mechanism. Okay. Do I want to necessarily take an anti-inflammatory if that's my survival mechanism for those cells? The pain is there to tell you something's wrong, not to just make it go away, right? But then if I'm like, okay, let's get you sleeping, let's get you off gluten, let's get you on some things that stabilize insulin and help your cortisol output, and let's change your toxic relationship with your work partner, then these other set of genes start activating. Instead of oncogenes and like pro-inflammatory and things that make us hurt and feel sick and have allergies and all sorts of autoimmunities, now all of a sudden you're like building muscle, you're calm, you're relaxed, you're sleeping, and this set of genes is now active. So technically, you can't necessarily just change your pedigree, but you can absolutely influence what genes get activated. And it's the same thing with modality. If you go to an acupuncturist and they put needles in the left part of your body, but not the right part of your body, you're going to get more activity from your arm on that side into your brain on this side, which is going to cross the side to the other side. You're going to get an epigenetic consequence. So absolutely everything will affect your genes all the time. And so what you want to do is just identify things that are maybe pushing them in a way that's consistent with their symptoms and move them away from that. And that's how you restore health and vitality rather than treat disease. The disease treatment model doesn't really do a lot for these genes. The sleeve that's up, that's pro-inflammatory. There's like, here's an anti-inflammatory, here's some prednisone, here's your emergency room visit. Oh, let's get you out of pain. Okay, but what about the environmental aspects, the physiological, the neurological, the immunological aspects that are causing these genes to be active in the first place? How do we influence those specifically? And that's kind of what I'm into. But to answer your question, I think the answer is we can affect immediate early gene responses very, very well.
I mean, evidently, it's a highly complicated, almost massive matrix of what you're looking for, what you're trying to optimize, the potentialities that could contribute to each of these systems. To what extent would you suggest it's an art form versus a science, as far as this is your cortisol number versus something that you've kind of grown to know and appreciate and be able to give insight on?
I think it is an art. I mean, that's why they call it practice. I hate to say it. This is my practice, right? So that's why generally practitioners that have been doing it a while, I'm almost 20 years into practice, what seems like intuition is just experience. You know what I mean? And so I think that absolutely it's an art. And just like I pick up a guitar and I can play a few chords and might be able to do some camp songs, like when Eddie Van Halen was picking up a guitar, it's a totally different experience because he's that type of artist. I feel like helping people is my primary art form, to really dial in on that.
And so to take these concepts and move into psychedelics and journeying, a lot of these diagnostic tools we've spoken about prior.
Yeah.
And you said that you could help potentially direct someone towards the substance or entheogen that might be most beneficial. Could you tell me a little bit about that process and how that works?
Well, it's kind of the thing, like what's a person's goals? Like, first of all, I'm not a medical doctor that can actually prescribe or recommend any of that, okay? But I live in the Bay Area. I moved there in 2007. I started hearing about this thing called Burning Man. And honestly, like, psychedelics freak me out because as a neurology practice, I would only see the freaky stuff that happened to people when they did these things. And I was like, holy cow, I'm never doing that. I never thought I would do that. Then I read Michael Pollan's book and I'm like, okay, I can see a lane where this could be absolutely useful. And I have done it and it has been absolutely useful. But I made sure that my brain was in a good spot before I did all that. And so the idea is, for example, psilocybin, everybody knows that's a serotonergic outcome, right? Everybody's focused on like the 5H2A, 5HT1, like with ayahuasca, 5HT1, 5H2A, and then like 5HC or 5H3C. That's the nausea thing, right? So it's like, well, where is serotonin made in the brain? I talk to people that facilitate some of these things, and they don't know where serotonin is made in the brain. You don't have to, okay? And I'm not trying to be self-righteous about it, but I'm saying there is a level of precision that we can marry with facilitation of these experiences. So serotonin's made in the area of the brain called the dorsi-raphe-magnus nucleus. And there's 3 levels of the brainstem where this thing lives. The top level is in something called the midbrain. And people that have serotonin issues in the midbrain tend to have like seasonal affective disorder. They tend to be really sensitive to light and sound because the very tip, just the tip of the dorso-raphe-magnus nucleus is in an area of the brain called the midbrain. And so if that isn't working well, that doesn't respond to light properly, right? So that would be a key history finding when I work with somebody. But like everybody in this room has gone to the doctor and the doctor has said, say, ah, right? And when you say, ah, you're looking at the tonsils, okay, you're looking inside the mucosa, you're doing all this stuff, but you're also looking at the arches in the back of the throat. And the arches can lift evenly or the arches can lift unevenly. And that's a midline brainstem issue. So people that have an asymmetry in their exam finding, or if we do a gag reflex with them and they have an asymmetric gag reflex, okay, or if we have them stick their tongue out and their tongue goes off to one side, or if we have them like open their jaw and the jaw goes to one side, they have a history of TMJ issues. All of those nuclei that control those motor systems live in the same or in the territory of the dorsi-raphe-magnus nucleus. So I might do a questionnaire with them that has a bunch of questions about serotonin, like for example, depression, but weepiness, does better with sweets, loss of appreciation in life, right? And they have those are all 3 out of 3. And then I do an exam and I look at their brainstem and their dorso-raphe-magnus, none of the symptoms, none of the exam findings are there. But remember, once the serotonin is made, it's delivered to the frontal lobes and other parts of the brain. So a person could have a problem in the factory not making it, and we see all those brainstem findings, and it's consistent with the questionnaire. Or they have a normal brainstem, but the frontal lobe, which responds to the serotonin, the exam findings are there. So it's like the serotonin's going somewhere, but by the time it gets there, that area is so inflamed, or there's been a concussion, maybe it didn't develop if they're on the spectrum. That part of the brain just isn't there to respond to the serotonin. The symptoms are the same, depression, but the exam will determine where you actually intervene. And that's why SSRIs can be kind of freaky, because like if you take an SSRI and you're making serotonin, the issue's in the frontal lobe, right? So now you're just recycling in an area where they don't have the metabolic capacity to deal with that, and that's where some of these black box warnings come in. And you can almost predict it by the exam how it's going to go based on the way I've been trained and what I've figured out. And I would love to see that conversation happening more in offices that are prescribing it. But right now they're kind of just going, hey, you're depressed, let's try this, let's try that. And there's obviously that's the standard psychiatric model, but there's obviously places that are doing amazing avant-garde things. In fact, they're happening in Santa Barbara right now. And so there's really cool stuff happening in psychiatry in the realm of psychedelics as well.
And so these diagnostic tools, though, that that you're taking advantage of, how does that say you run the diagnostic test, mm-hmm. and then you can say, well, potentially ayahuasca might not be the thing you're looking to do if you have anxiety or depression, or maybe you should look at psilocybin. Are you able to give that type of data so someone can optimize their experience? And what does that look like?
Yeah. So like, what about like, if somebody has what looks like, a concussion in an area on more of the right side, if they're right-handed, and they have, history findings where they're already showing no serotonin symptoms whatsoever, but they have a bunch of dopamine symptoms. There's kind of this teeter-totter relationship between dopamine and serotonin in the brain. And if you're good on serotonin and then you just have a bunch of dopamine symptoms like lack of focus, OCD, certain types of OCD, depression, but more like the depression where people walk into your house and they're like, are you depressed? But they don't really know. Like their house is just in disarray. Maybe they're a little disheveled. They don't really understand they're depressed, but things just aren't going well for them. they crave things like chocolate, cigarettes, red wine, red meat to try to get their dopamine. They might be addicted to their phone. They might be addicted to video games. Okay, if they have more of a serotonin and a dopamine issue, they may have an amazing experience with psilocybin, but the net result of that, the afterglow, is not sweet. That's apathy. It's a type of depression. It's like you can't get them going. They can't get back to their normal life. They're actually losing focus. They're losing motivation. They may go into ahydodenia, which is they don't enjoy the things they used to enjoy because they've further depressed their dopaminergic system. And so their exam findings might be consistent with maybe they have a little cogwheel rigidity, or maybe they have a little stooped posture, a stiff shoulder, a history of constipation, a masked face. And you're like, okay, this person actually has normal serotonin, but they're showing dopamine symptoms. They may not have the journey that they want, but they actually have the serotonergic system to respond to those things. It's just the afterglow, the aftermath of that. There's a way to actually marry long-term stability and long-term quality of life with that journey. And so that's kind of what we were discussing on the phone before this, is like, well, what do you want to talk about? I want to say there's a biological basis for this, and we can be absolutely more precise using history, using exam, using forms, and then working with facilitators to make it a better experience for everybody. And that's what I'm super into.
And so say you had this data, what would you say to the facilitator? Would it be a supplement regimen, or would it be some after or follow-up care? What would that look like?
Well, okay, it could be supplements. It could be brain exercises. It might be a referral for medicine. Look, people are so against psychiatry. Just, they have philosophical biases. My job is to not be biased. My job is to be open and talk to them about what's in their value system. And I absolutely know people that have benefited from, dopamine reuptake inhibitors. It's changed their life. And you're not going to get there with like a supplement. Like, there's just benefits to medication. Some people genetically just don't have the response to things. There's a really cool test by Genomind that looks at these different receptor pools. I can't remember the name of it off the tip of my head, but it's really cool. You could do a Genomind test and look at your serotonin SERT reuptake. And listen, if you have a SERT issue and your reuptake is slow, you're going to have a different experience than a person who takes like psilocybin and has a rapid reuptake. It's going to be different for you. You might be the person who does ayahuasca and like is completely nauseous because you have that genetic predisposition. So like, if you have the cash to do that and you do the test, you're like, actually, I could avoid this like 5-HT2C or 5-HC receptor altogether by not doing ayahuasca and do something like psilocybin or DMT and avoid the nausea, but still have that psychedelic experience. Wouldn't that be cool?
So you can take, so I understood you properly. You can take ayahuasca and not get sick?
No, like you might just go, actually, I have this 5-HC thing that tells me that I'm more likely to get nauseous if I take certain psychotropic meds.
Right.
And we know ayahuasca influences that. So maybe ayahuasca isn't your jam unless you want to be purging.
Yeah, when I did ayahuasca,
I purged
every single night, 60 days, every single night I threw up. I feel like that's kind of the part of the process.
Some of it is traditional idea about what vomiting is. I think some of it is that. I think some of it is that you're just puking. So how do you know if it's the Shipibo idea that you're having a purge and you're getting out bad stuff versus you just genetically don't do well with that particular substance? You can't really know necessarily, but what you attach to the experience does matter. And so like, I believe in the Shipibo idea about how to do ceremony. And I also believe that some people have the genetic predisposition to have a really nasty experience with anything that stimulates that receptor pathway, and they might do better with another type of experience. So I don't technically advise them to do that other experience, but I help them understand probabilities, or if they've already done that and it happens every single time, help them understand that might be it.
So specifically mystical experiences, when people have mystical experiences, they typically take a little bit more away from it. Their depression potentially goes down, their anxiety dissipates, or at least it seems like potentially a portion of their intention is fulfilled. Do you believe that putting too much science into an experience that's highly spiritual and largely ineffable will detract from the overall experience?
I mean, it can for the individual, but I think that there's this idea that there's a romantic notion about journeys and ceremony. And then there's this idea about understanding what's actually happening. And there's this idea that they need to be at odds with each other. And I reject that idea. I think a better understanding can be useful. And I don't think that understanding that if you're having a mystical experience in DMT and functional MRI says it's because you're having a increased frequency of firing in the lateral temporal lobe, that demystifies the experience. You know that you're having an experience. We know that experience happens in the brain. It's just saying where it is. It's like, okay, we've just identified the region. Okay, but like, what if that person who does DMT doesn't have the real capacity to respond to it because of a head trauma there? Oh, hey, maybe we want to do something else that isn't so much localizing to the lateral temporal lobe. Maybe we want to do something that's more for the frontal lobe or for the parietal lobe. Or maybe we do meditation instead for the dorsolateral part of the brain. Or maybe we do something like hypnosis to try to access the default mode network through the insula. So these are just different ways of talking about the brain, and say it can be really overwhelming, the terms, but just think of it like when you got here, you went down whatever road you were to get here. And so on my brain, I'm just kind of mapping out these different, the insula to me is like the Autobahn. Okay. The dorsolateral prefrontal cortex is just like a neighborhood that my friends live in. You know what I mean? So the way I try to remember stuff is like by attaching it to what I already know, and just instead of being overwhelmed by the terminology, just saying, well, this is where this lives, this is where that lives. And I believe that there is a way to combine that knowledge with facilitation to demystify some of the, not mystical experiences, but some of the experiences that go bad, that make people scared. Maybe if you deal with your anemia and your concussion before you have a journey, maybe you're not going to have this like abject depression when it's over and your life is forever changed in a way that you don't know how to get it back. You know what I mean?
Absolutely. I mean, that makes a lot of sense. And I think most people would like to have a positive experience with an afterglow that persists in whatever problem they want to hopefully do a little bit of work on. The work has been done on it. But you did mention a word, neuroplasticity. And with neuroplasticity comes up cognitive flexibility as well as the default mode network. How do those three play a role in some of the neurochemistry that we've discussed in your approach? And what does it say about the psychedelic experience?
The default mode network is really cool. Default mode network is, well, hopefully none of you are in it right now, but basically like it's what you default to when you're not attending to a task. And so if your default mode network is laden with like negative belief systems about yourself, then you could see the best doctor in the world and you're just going to cycle through this negative belief system. And it's going to create a number of genetic alterations or activations that aren't necessarily going to serve your health and vitality. So the default mode network can, let's say like you're like, okay, cool, I heard that lion's mane is awesome for plasticity. And let's say your default mode network is putting you in a place of self-loathing. And then you take lion's mane. What's going to happen? What could happen is diabolical learning, which is your brain goes the other way. Plasticity can go many directions. So I love supplements. I'm a huge fan of supplements. They freak me out. People take supplements and they give up on them, but it's like, you can really hurt yourself with supplements because you can, let's say like I have a brain that likes to be anxious, and then I take supplements like turmeric or resveratrol or like anti-aging antioxidant supplements like cacao or something. It's so-called anti-aging, and I lower my inflammation. And my anxious brain becomes more efficiently anxious. That can happen. Okay, so like I love nutrition. Clinical nutrition is one of my passions. I'm a huge advocate of it. I use it in my practice. I think that it's as scary as me like getting under the hood of my car and doing any good in there. You know, I think that there are experts in clinical nutrition for a reason, but sometimes experts on TikTok, okay, may not be the ones, you know what I'm saying? I don't know if I want to say that, but I'm just saying, if you talk to somebody who does clinical nutrition, try to distance yourself from a serious protocol, because they might not be seeing you. They might be seeing a protocol, and protocols can be useful, but there's just another level, which is like precision.
And what you said about supplements, I mean, I've always been interested in nootropics. What's your take on nootropics? Because that's kind of, those
Let me
are,
set this down, yeah.
those can kind of have more of a speedy quality or a cognitive enhancement quality, and they're also not very well tested apart from Russia in the 70s and 80s in general. But yeah, what's your opinion?
I love nootropics. And what does a nootropic do?
I mean, many different things, but cognitively enhance you, hopefully.
It cognitively enhances by increasing the frequency of firing, supposedly, or supporting the health, supporting the output of a network of neurons. I use nootropics a lot. I more from like a amino acid perspective than like a medication because I can't prescribe. However, if you give a medication that's supposed to increase the output of a neuron, again, and that person has anemia, that person has what's called a tauopathy from a blow to the head. Let's say you and I were a neuron and I'm releasing dopamine and you're taking dopamine. For every one of you and I, there are 10 immune cells called glial cells that help with what's called plasticity. And these glial cells, when we're born, they have legs and they kind of float around. They're called ramified. They're in a null state. But when we hit our head or go through a significant trauma or have a significant infection, they lose their legs. And they're no longer the null state. They go into what's called the ready state. And that can happen like when you're a kid. Like when I was a kid, I was dropped on my head. My brothers always remind me of that. Dropped on my head. But then when I was a teen and things kind of started getting heavy in my family, those glial cells that were basically no longer in the ready state or in the null state went to the ready state, and then they got activated by stress. And it looked like I was having anxiety, but what I was having post-concussion syndrome because the stress activated those glial cells. That can happen too. You can get Epstein-Barr and you can activate those glial cells. You can get COVID, you can activate those glial cells, right? So if you take a neuropic and nootropic and you have a glial cell that's in what's called an M1 designation, maybe nothing happens. Or before you take that substance, did they evaluate your capacity to digest and absorb? And was there any sort of evaluation as to why you might need it? Like, did you have a blow to the head there? And so that neuron system is down, and that's why, rehabbing it and then supporting it with that substance is like almost like peanut butter and chocolate, when they came together. It's like a cool thing, like a lot of candies have that, right? So it's an amazing combination. But sometimes nothing happens when like a lot of people have taken that, right? And like, what happened? Nothing. But why? Did they not take enough? Was it the wrong version of it? Did they have a malabsorption issue? Did they have an increased clearance issue? And so I'm always curious when people take those, like, how did it go? Did you have any negative symptoms? Did you get the diabolical learning thing we talked about? Was it a positive experience for you? Because it can happen. It's awesome when it does happen. And then it tells me a lot about that network. So I'm a huge fan of them, but I also think, and I'm going to show you an exam a little bit later, how you can check this on yourself. Okay. But you can make a maladapted system more efficient with a nootropic. And then you can feel good in the moment, but long-term do harm. And so I just want to show you like a really cool tool today. And whatever you're doing, just use that tool and make sure that it's improving that part of your exam. And if it is, then cool. But if it's making it worse, you're kind of taking your chances, really, neurologically speaking. I'll explain more about that later.
So it seems like before I should take lion's mane or turmeric or almost any supplement, I should get your diagnostic test because I could be poisoning myself with diabolic. What was it? Diabolic learning?
Yeah.
That doesn't sound very fun.
Yeah. Well, the importance of a baseline is critical. You just having a baseline, getting a baseline exam.
I'm afraid of turmeric now. Anyway, so there was something I wanted to touch upon, which we've kind of danced around. But do you think with science, say 20 years down the road, 30 years down the road, 50 years down the road, that we'll be able to distill every aspect of our conscious experience to neurochemistry and neuronal firing, or even 100 years from now? Do you think everything we need to know about consciousness is found in the brain, or what's your take on that?
The brain is just the instrument. It's the receiver and the transmitter. I think that, no, I don't think we're going to understand all of that. I don't know that we're meant to understand all of it. I think we'll understand more. We're understanding more. Like, for me to stay current in science, I have to read 16 papers a day. I don't read 16 papers a day. It's crazy right now. There's so much information. Okay, but I do believe we're going to understand more, but I don't think we're going to ever understand it all.
And so in reading, how many papers a day? One paper a day?
1 to 2.
That's a lot. 600 a year. Nevertheless, what's the type of research that you find most exciting, and what direction do you think we're going in? And is there any technology that you're particularly excited for?
I'm really into clinical nutrition, so I'm really curious when I can find novel applications for substances I have on my shelf. Like when everybody started getting long COVID, or when they started getting COVID, there's a particular amino acid that can help with the microvascular problem that happens with COVID in the acute stage and the subacute stage and in the long stage. And there was really cool research around it. And so like I get really geeked out when I see that. And then also like there's a million different modalities that are out there. And when I learn a new modality that can help me help somebody much faster, and I can acquire that modality if it's like a piece of equipment, or if it's as simple as like rotating differently in a chair that I hadn't considered, like staring at their thumb instead of just like with their eyes closed. I get so excited about that because now it just opens up an entire avenue of results. When I first learned about hypnosis, it's so interesting. I learned about it for pain control through the default mode network. But then what I learned is that some people, when I examine them, they have a history and they have forms of a particular, like it looks like it's going to be here, but you don't see it. And then you put them in hypnotic change, or you hypnotize them and get them deep, and then examine them when they're in hypnosis, and you can see it because it was hung up on the default mode network. But when you're doing an exam with somebody, they're attending to you. So they're not in their default mode network, but you hypnotize them, you can get them in that state, and then you can find it. So that kind of stuff, like when people are doing research about their thing, I get really excited about, I just have a knack for seeing how that might have a novel application. So pretty much all on everything new, I'm really into that. And then I'm not cavalier with my patients and clients, but I'm more excited to share with them the possibility. And then I use my exam to see if it worked or didn't work.
And is there any element of bioneurofeedback or electromagnetic stimulation, transcranial stimulation to the work that you do? And do you see there to be any benefits to that type of technology?
I absolutely refer out for transcranial. I don't have it in my clinic. I think it's a great modality, particularly if the area, the nidus of the lesion is the dorsolateral prefrontal cortex, particularly on the left. I really like to refer out for that more so than if it's on the right. When I refer out for that, I know that that's where the issue is. So the dorsolateral prefrontal cortex, it connects like fiber optic cable to all these other areas. So like, let's say we talked earlier about saying, or sticking your tongue out. If there's a bunch of stuff going on there and that area connects with the dorsolateral prefrontal cortex, doing transcranial magnetic stimulation might get a short-term benefit, but the issue is further south. And so that I would prefer to do exercises further south, like mother feeds child kind of thing, and then see if it changes. And if it still doesn't change and their exam is looking good, feeding that area, then I'll refer out for that. Neurofeedback is another great, neurofeedback's amazing. Neurofeedback, you put these electrodes on your head and you can determine like what waveform that area of your brain is firing on based upon these instruments. It's amazing. But again, neurofeedback, I think the strength is if you have a primarily cortical issue, which is the top layer, there's 6 layers of the cortex, okay? And if you have like, think of the crust, you have a core, you have a mantle, or the earth, you have a core, you have a mantle, and you have a crust. If your issue is on the crust, my experience is neurofeedback is awesome because there's nothing in the core or the mantle that's causing the crust to have a problem. But if your issue is in the core, like for example, the brainstem, and you have like a primitive reflex, like a Gallant reflex or a Moreau reflex still as an adult, should integrate when you're 8 months old. If you still have that, it's no wonder you have anxiety. You never developed the part of your brain to regulate your emotions. So neurofeedback for that person, I've found, tends not to work. And the reason, but my confirmation bias is I only see the cases that it didn't work, right? Because if it worked for them, then maybe they wouldn't be in my office. So it might be working, but my experience is if you get to the core issue and then start at the bottom and work up, it's more successful. But I love neurofeedback. I refer out for that as well, for anxiety a lot.
And in the case of the individuals whose brains didn't grow, like you were discussing about those 2 different cases, is there anything that can be done for that person, or are their brains permanently stunted? And
it depends. So if they had birth trauma and they had a stroke, maybe not. If there's 3 different types of neurological processes that have to happen in utero, And if those things didn't happen and they come out and they don't have primitive reflexes, that's not a good sign in terms of autism. But if they're born with their reflexes, but then they just don't integrate them for various reasons we won't get into, then there's a chance. Okay, now a child's brain cooks in its skull until they're 25. So the soup is still cooking when you take it off the burner. The brain is still cooking when it comes out of the birth canal. And until you're about 12 for girls, that's when the gray matter peaks, which are the cell bodies in the brain. For boys, it's 14. And then for both men and women, it's 25, the white matter peaks. So if I catch somebody with issues in those windows, I have a greater opportunity to affect their ceiling. But the brain is very plastic. So I see people of all ages, and I'm able to help them connect networks that maybe I can't help their ceiling anymore, but I can help them integrate and function better. It's like learning, basically. It's an education instead of a treatment.
And so say someone that was not up to the age of 25, under the age of 25, would you suggest, given what you just outlined, that they don't consume alcohol and cannabis and other recreational psychedelics?
I mean, look, alcohol is not a health food for most people, right? Cannabis, I really freak out, okay, the way cannabis is being used for children before their brain is developed. It kind of freaks me out, to be honest, but I see the value in symptom changes, okay? But I'm more of an advocate, instead of giving a substance that can activate a network and then eventually can downregulate a receptor pool, why don't we just understand that network needs help and just give brain boot camp for it instead? You know, it's more of a transformative experience rather than a dependency. I'm really an advocate not for dependency.
Right. No, and that makes a lot of sense. So I believe that you have an interactive portion. But before we do that, we have this thing called the Change Your Lens questions, which is one of my favorite portions because we get to ask many different interesting people from all walks of life a set of standard questions. So we're going to do that real quick before we hop into the interactive exercise.
Okay.
So to start off, what person or mentor influenced you most?
I would say Datis Karazian. He actually practices in Carlsbad. Anybody know Dr. Karazian? Karazian Institute. He's an amazing, he's also a chiropractic neurologist. And one of his colleagues, Sam Yannick, between those two, those are probably the two. They taught me the most about how to be open-minded and work with clients from that framework instead of just having a singular idea before I even see them. How to properly work up somebody with labs, how to go through a case review process. They taught me about neurology and immunology and endocrinology. So probably Dr. Karazian and Dr. Yannick.
You're on a deserted island and you're only allowed to bring one book and no one's ever going to find you. Don't say the DSM or something.
Yeah, one book. Gosh, probably The Anatomy of Peace.
Is that an anatomy book or is that a philosophical treatise?
Philosophical book about how we can deceive ourselves and in that process isolate ourselves from people, and we can be robbed of our internal peace.
Only one album on a deserted island.
Siamese Dream, Smashing Pumpkins, without a doubt. All day.
Okay, you're on your deserted island and people finally show up. They didn't bring any books or albums, sadly, but you get to create a cult or a religion of sorts. What would it look like?
You know, I saw this question. I'm diametrically opposed to being worshipped or being part of that. So I would just say I would bow out of that.
You're not being worshipped. You're having someone worship something else, or you're creating a metaphysics, essentially.
Okay.
It's really a cosmology.
So, okay. The question then is, the answer would be, I believe that a lot of human suffering is a result of holy wars between factions of people that want to transcend death. And so if they transcend death by vilifying a particular group of people and they feel righteous to do that, and when they die, they get their just reward, I would like to create a cult where we don't do that, where we don't actually engage in holy wars, and we can actually transcend that and find common ground instead of like saying, I'm doing it this way is better than you're doing it.
I'll join your cult. That sounds like a great cult. Yeah, I won't worship you, but I'll join your cult.
Yeah.
Next question. So I was reading something a number of years ago, and it said Bank of America said there's a 56% chance that we live in a simulation, which I just thought was a strange thing for Bank of America to investigate. Nevertheless, what's your opinion on that? Do we live in a simulation?
I just walked by a Bank of America that was closed yesterday, so I don't know. I would put too much stock in that. I don't think we're in a simulation, personally.
Do you believe in life after death, and do you believe that psychedelics give us a little bit of an insight into what potentially life after death might hold?
Well, gosh, I just experienced something a couple weeks ago where I feel like maybe I experienced what death is during a psychedelic experience, and I'm no longer afraid. And that's been amazing. I can't even tell you, if you've gone through that, how awesome that is to feel that. My idea about that is I don't feel like I will be me. So what I experience and what I think could happen is we, like a dandelion disco, and we become part of in the Taoistic idea of this well where we all come from, and we go back to that. But I don't feel like I'm going to go see, sadly, I don't feel like I'm going to see those that have passed before me there in the same state. But it was so peaceful. Didn't hurt. It was amazing.
Very cool. Thank you for sharing that. If you could take any drug in any location with anyone alive or dead, what substance would it be? What would you do for your trip, and with whom would you be tripping?
I don't really have a lot of experience in that world. I'd really love to meet Jim Morrison. Yeah. So, I don't know what drug it would be. Maybe a cup of coffee with Jim. I know it's not very exciting, but yeah.
Maybe a little bit of whiskey in the coffee.
Yeah, there we go.
All right, the whiskey bar.
I make an exception for him.
So, substances that you have not tried, what are you most fascinated in exploring?
I've never tried DMT by itself. I'm interested in that. I don't know that I ever will. I've never done ketamine. Never tried that. That's something that's interesting to me. Those have come to mind when you asked me that question.
And then lastly, and we've kind of touched upon this in the interview, but what is the nature of consciousness in 60 seconds? Go, Jacob.
The nature of consciousness in 60 seconds. I think consciousness is all around us, and our brains are tuned to certain levels of it, and we either attract certain parts of it or we repel certain parts of it. I think consciousness is the information by which we derive all of our artistic expression and ideas, and I think it's awesome.
That was an awesome answer. Well, can we give him a round of applause just for this first little interview? And now I'm going to let you kind of take the stage, and then we're going to do some Q&A afterwards, after your presentation. Is that correct?
Okay, how much time do I have?
Until you want to leave.
All right, All right, it's too late. I can see it already. So what I wanted to share with everybody today is a diagnostic tool that you can use to kind of evaluate how things are going with whatever you're doing. So whether it's exercise, whether it's therapy, whether it's meditation, whether it's a substance, whether it's a journey. I picked this part of the brain because it's pretty easy to teach, and also because in the research, there's something called central immune depression syndrome, which, we've all heard of people that maybe you haven't, but if they get a stroke or something happens, they're worried about an infection. They're worried about them maybe dying right after the stroke. There's grades of that. So there are a lot of people that have these cerebellar issues that actually are permeating their experience, leaving them vulnerable to things like autoimmunity, cancer, cardiovascular risk, stealth pathogens, not able to fight things off. And so I want to show you some exam findings that are related to this part of the brain called the cerebellum. In fact, the cerebellum has more neurons than any other part of the brain combined. It's back here. It coordinates movement. So we're all going to be sheriffs today. We're going to do our little roadside alcohol poisoning roadside DUI test, okay? And so if you all could stand, you might want to take your shoes off. So first I'm going to go through the actual exam, and then at the end I'm just going to talk a little bit about what it means if you have these findings, okay? And then if you want, I can send the papers that I based this little thing I'm sharing with you to Jacob or Cole, and then in the next newsletter they send out, they can include those papers if you want to peruse them. So I didn't just pull this out of thin air, okay? But basically, if you put your feet together, this is called Romberg's test, okay? Now, if you want to just stand, actually grab somebody next to you. So one person do this, and then the other person watch them, okay? Because some of you actually could do this test and fall over and hit your head. So just like grab the person next to you, decide who's going to do the test. What you do is you put your feet together and you just close your eyes. Okay? If you can face each other, yeah. And then look to see if there's a sway. Just look to see if there's a sway. Eyes closed. Do you sway to the left? Do you sway to the right? Do you go front? Do you go back? And then just switch partners, okay? So then just switch. Just kind of make a note if there's a sway. So feet all the way together. So don't touch them. Don't touch them. Let them sway. Okay, so just make a note of that. Okay, now the next test, the next test is something called Romberg's test. All right. I know this is fun. Hang with me. Okay, we got a few more of these. So listen, if you did the Romberg's test, which is you close your eyes, you put your feet together, and you kind of did something like this, then the side you sway towards could be a side of the weak cerebellum. I'm going to explain why that's a big deal after this, okay? The next test is what's called a sharpened Romberg's test or a man's test. Take your right, so decide who's going to go first. You might want to stand near them or behind them for this one. Have them put their right heel in front of their left toe, so heel to toe, and just have them cross their arms like this. Okay, if they can't do that without falling over with their eyes open, then don't have them close their eyes. But if they're not falling over, have them close their eyes and then see if they tip one way or the other. Okay, it's called sharpened Romberg's test. They should be able to do that for 10 seconds. All right, so have them hold it for 10 seconds. If you're swaying one direction, I see some people falling over. Okay, then switch sides. Do the other side, okay? So put the left foot in front of the right foot.
Yeah.
Okay, and then switch partners. Okay, and switch partners and do the same thing. Left foot in front, then right foot in front. And then if you fall on one side, the foot back is the side of the cerebellar issue, okay? So if you fall like with your right foot back, it could be a right cerebellar issue. Now, it could be a foot issue, okay? But let's just say I fall with the right foot back. Just make a note of that. Okay? All right. Looks like most of you are finished with this. Okay, so the next test. Okay, everybody face me. Go like this. Okay, first of all, do you notice any tremor? Okay, is that looking nice and steady? Okay, pay attention to that. Okay, and then go like this. And then go like this. And then go, watch me, back and forth as fast as you can. There we go. Come on, keep up with me. Okay, now, I see some of you, one side's a little floppy, one side's slower, okay? The side of the slower side, or if it's starting to get a little jimmy arm or something, that's the side potentially of the cerebellar issue, okay? That's called dystatokinesia. Now, you can do that arms extended, and that's getting one somatotopic representation of the cerebellum related to the shoulders, and then you can bend your elbows and go like this, and this is getting another representation called the dentate area of the cerebellum, which is more connected to the neocortex. So you see a little bit going on here. So lot of you are going to notice that one side's a little funky, okay? And that could suggest that there's a cerebellar issue on that side and a cortical issue on the other side. And we're going to talk about the significance of that after we all do this together. Okay, the next test is finger to nose. Okay, so just all hold your arms straight out in front of you. Okay, and let me just grab you here for a second. Okay, I'm just going to demonstrate how to do this on your partner. Okay, what you do is you have them hold their arms, close your eyes. And what I want you to do with your eyes closed is touch the tip of this finger to the very tip of your nose and bring it back. That was beautiful. Okay, and then let's do the tip of this finger to the very tip of your nose and bring it back. Okay, just a little off, okay, but try that on your partner, okay? So actually touch their finger, have them do it, and see if they know where their nose is. The tip of the finger to the tip of the nose. All right, so a couple more, then we'll discuss the meeting, okay? Next test, you might need your light on your phone. Okay, you just have your study buddy say, ah, and what you do is there's little arches in the back of the throat, and just look to see, is one arch higher than the other arch? Okay, so you go, ah, like really, and then just look to see, is one of the arches higher than the other arch? Okay.
Oh, did you say it's loud?
How many people are seeing asymmetry on their partner on that one? On the test? Very common, okay? So that's a midline brainstem issue. Ever heard of the vagal nerve? Okay. Yeah, you want symmetry as much as possible, okay? All right, so the last one is just have your study buddy stick their tongue straight out as far as they can and see if it goes off to one side or not at all. Just straight out like this. Protrude it straight out. And then see if it like shades to one side or not.
Well, if you is.
Good. Okay. All right. And then when you're done. Okay. So when you're done, you can take your seats. If you want to put your shoes on, you can. Yep. But I might bring somebody up here too. So we'll see. Yeah. Right. Yeah. We'll talk to the district. We'll get it sorted out. Yeah. Okay. So this test here is called Romberg's test. All right. And so it's just kind of a non-specific test to see how your balance is. So if you're going off to one side, generally you're going to go to the weak cerebellum. Okay. If you're doing dystatokinesia and you're like a little funky, I can't do funky on this side. Okay. So if you're a little funky on one side, this is generally the weak side of the cerebellum. Okay. The cerebellum connects to the opposite brain generally. Okay. If you're doing finger to nose and you miss on one side, or you see this, like where they start shaking, so they're good here and then they get here and they start to shake, that's called an intention tremor. That would be a cerebellar finding, okay, on that side, on the side. Now, if they have bilateral shake, they have bilateral shake. I'm not actually shaking, I'm just demonstrating that. Okay, Sharpen Romberg's test or Mann's test. This is, again, the back foot tends to be the cerebellar side. So if I do this and close my eyes and then I'm like, oh, I fall over, generally, no matter which direction it is, that could be a cerebellar issue. Now, the cerebellum, we know that if you have too much alcohol, a lot of these tests are tests that police officers will do to see if you have a toxic state that doesn't allow you to coordinate movement, and therefore you're unsafe to drive. Well, a lot of people don't realize this, but that also coordinates your immune system. It helps coordinate your neurotransmitter release. It helps coordinate the activity of your frontal lobe, so limbic regulation and cognition, basically mood and thought. And so if these are asymmetric, then there is a potential for asymmetric coordination of your immune system. And what does that look like? That looks like allergy. Okay, that looks like autoimmunity. That looks like chronic infection. That looks like the person who reacts to every single food under the sun. That's the person that has eczema. That's the person that has asthma. They're just reacting to everything. Okay, and so I can tell you that the majority of people that I see are being treated medically for things and they're getting good results in terms of control of their symptoms for asthma. But then we do an exam with them and they have the asymmetry and we see their labs and they have like labs that show like polarized immune responses and they maybe can't digest and absorb supplements very well because their vagal system is influenced by all this, the vagus nerve, okay, which is the thing that gives us stomach acid secretions and digestive secretions and gut motility. And so they're just not going anywhere. But then we do something, and instead of being like this, they're like this at the end of the session. They're like, oh, I can breathe better. Okay. And they do that for a few weeks and suddenly their labs aren't looking polarized. And then they find that they're not needing to take their steroid inhaler as often. And then eventually after a while, they just might set that down. Okay. And they have it for emergency purposes only. It's pretty cool. If you stick your tongue out and it goes off to one side. Now, in the world of neurology, a hard lesion is you're going to could be really stuck to one side. Okay. And you're going to go, away from the side of a stroke in a hard lesion. Okay. So you have a stroke over here, you might really stick it off hard. Okay. To that side. But if you have what's called a soft lesion, so let's say, I go like this and I'm really slow on this side. And then that cerebellar firing doesn't fire into the left brain as much as it do the right brain. And then that left brain doesn't fire to the brain stem at the level of the medulla as much as the right brain. I'm going to be a little asymmetric in my tone there, and my tongue is going to stick a little bit towards the weak side. Now, the medulla regulates things like bladder function. It regulates our essential things to stay alive. So if you ever heard of somebody that has dysautonomia, where they're stuck in fight or flight, it could be because the medulla oblongata has asymmetric tone. And is it because there's a problem in the medulla? Is there a problem in the frontal lobe that fires in the medulla? Is there a problem in the cerebellum that fires into the frontal lobe that fires in the medulla? That's just it's new terms to you all, but it's just like taking a right on State Street and then taking a left on whatever road it is to get here. I can't remember. Okay. All right. So it's really not that complicated once you get used to it. It's really that straightforward. It's pretty cool. So whatever you do, check in on this exam. Did it improve? Did anybody not have any exam findings? Everything was awesome. No asymmetry. Well, of course you would, right? That's so cool. Who's your doctor? Yeah, right? Okay. So the idea is you do these things and you decrease probabilities. So I'm not saying that you can't have cancer if you have a symmetric brain. I'm not saying that you can't have autoimmunity, you can't have asthma, you can't have eczema, you can't have acid reflux, you can't have anxiety, you can't have depression. But I'm saying that if we remove that biological things that are going awry, that are underlying causing the condition, then you can have a restoration of function. It's pretty cool. So if you're into the psychedelic experience and you're into the world of experimenting on yourself, because basically that's what's happening is people are just winging it and they want to get something from that experience. And it's amazing. I've personally experienced it. Okay. But I also work in the Bay Area, and like I was saying, there's this thing called Burning Man. Okay. And then I see people after Burning Man. Now, are they that way because they didn't sleep for a week? Is it because they weren't eating properly? You can't just say it was the substance. Okay. But I've seen a lot of people that didn't go to Burning Man, and I've seen people, and you take a history and they do their journey and they had an amazing experience, but then they can't get out of bed for a month. Okay. Well, why is that? All right. And we just do an exam. But if you have a baseline and your baseline looks even worse after your journey, try to do something about it. Okay, see if you can find somebody to help you. It doesn't have to be somebody that does what I do. Go to your body worker. Have them do body work on the side of the cerebellum that's diminished and just see if that helps you. Okay, so I'm not here just saying I'm the answer to all this stuff, but what I'm saying is now you have a tool to evaluate whether what you're doing is helping you or harming you. And that's what I wanted to share with you today. It's just a simple biological basis looking at your brain, because this part of the brain is involved in the coordination of immune responses, cardiovascular responses, cognitive function, and emotional regulation. No big whoop. Pretty cool. Okay. All right. So yes.
What happened to this test where you do that both?
Yeah. A person doesn't have to have a unilateral issue. Not all of this is a brain issue. Okay. Just so you know. So you could have a falling off to the left with your left foot back because you sprained your ankle. Okay. But look, if you sprain your ankle, you're not walking on it the same way. You walk 6,000 steps a day. You're getting more stimulus, healthy stimulus from your right foot into your right cerebellum and your left brain, and you're not getting healthy stimulus from your left foot into your left cerebellum and your right brain. What's going to happen? Asymmetry. Okay, and listen, asymmetry is wonderful. Asymmetry gives us so many cool things in terms of artistic expression and talent, but what it can do is it can cause rigidity, it can cause lack of flexibility, and it can contribute to disease process. So it would be cool if you just had the choice to be artistic rather than just be artistic and then have all these concomitants that go with it. Well, that could be It could be your cerebellum on both sides. It could also be you have a foot injury on both sides. It could be peripheral neuropathy. So my office, I don't have a protocol for somebody that falls, but what I wanted to show you today was just look at that. And do you like to do psychedelics? So when you do your psychedelic, give it a few days, however long it takes for you to kind of recover and get your rest and sleep and your nutrition in, and then go back and check that and see if it improved it. That would be awesome. Okay. And the idea then is if we see this improvements, well, why can't we just quantify that and put that into research so we can actually show some of the medical utility for psychedelics instead of just saying, oh, they're this scary thing that everybody should avoid. Okay.
So it's not exactly a question, but can you speak to the whole experimentation thing? And one thing that District216 is wanting to do is to decriminalize psychedelics, etc., and use it as medicine. But what about all the people out there that are experimenting? And do you think about that much? And do you have some solutions about how we can open up the psychedelic experiences and be safe?
Well, yeah, I think getting a baseline exam would be a good way to do that. And, listen, if the thing is, if you decriminalize things, then, okay, what can of worms are you opening up for regulation? And then is the access actually going to go down and then be put in hands of people that have licenses to prescribe it, but maybe don't have the experience to prescribe it? So I think that is a awesome question, way above my pay grade. Yeah, sorry. But I really do think that I'm not a huge fan of children or even people that don't have fully plastic brains doing that necessarily. I'd be more inclined to say later in life would be potentially a better spiritual benefit, although that's just my opinion. People could totally disagree with me on that. But I think later in life would be a safer bet for most people than doing it early in life before their brain is formed, especially if they have a bad experience that can haunt them for the rest of their lives. So like when you have, my experience with psychedelics has only been in ceremony with people that have been directly trained in the lineage of an indigenous culture. And in that situation, I would leave that up to the shaman to decide who it's safe for. And I'm definitely not the person to make the call on that because they've been doing that for generations. Who am I to say? But I'm a little inclined to say I wouldn't want children or people under the 25 to engage in that.
I was wondering if you had any ideas about how breath work or even energy journeying would affect the body, and if there were like sort of contraindications for that.
Yeah, so breath work is amazing. So when you take a breath in, you actually activate your sympathetic nervous system. So like if you do that thing where you breathe in like 4 breaths and then like make it harder to breathe out, as you relax, you're actually activating your parasympathetic nervous system. So there's some benefits of helping people stuck in fight or flight. Everybody knows that. Also, breath work is cool. There are whole fields that are basically revolving around breath work that help with oxygen saturation, and it can be a tremendous way to affect pH in the body. And so imagine like there's a bunch of workers outside that are working on the road and they're laying asphalt and it's like 130 degrees. They're not going to work as efficiently if it's 130. They're not going to work as efficiently if it's 20 below. But if the temperature's right, they work optimal. Well, we have these enzymes in our body and they function at an optimal pH. And you can affect pH with things like alkaline water and like diet, okay? But you can affect pH very quickly with different types of breath work. I do see like some types of breath work that alkalize the body, like, okay, blowing off CO2 very quickly. It can provide like a euphoric experience, but changing your pH has consequences. And so I'm not a huge fan of like using breath work that way, but I'm more of a fan of using breath work and to control like the fight or flight versus rest and relax. But it's tremendous. And using breath work is part of what I do in hypnosis to help understand that I'm accessing the brain properly. So I think it's wonderful. And another little tip that I use a lot is I'll do alternate nasal respiratory technique, if you've heard of that. So people that are stuck in a really significant anxiety response, they can do the alternate nasal respiratory technique, and it can work for like 10 or 15 minutes. Cool. Well, look, that pulls them out of it for 10 or 15 minutes. If they have to do it in 10 or 15 minutes, then do it in 10 or 15 minutes. And then eventually they're not going to need to do it anymore. So it's pretty cool. I'm a huge fan.
I'm fascinated to hear what your near-death experience was like and why you're no longer afraid, as somebody who has had a near-death experience, but not through psychedelics.
Well, that's interesting because other people that day had a different experience, and I'm glad I didn't have that experience. But for me, I had taken ayahuasca, and I didn't know. I got to a point where it was dark in the room, and I started to see like what looked like a topographic map of like mountains. You know, when you look at a map, how the rings are close together if it's elevation. I just saw these rings everywhere. Eyes open, eyes closed. It didn't matter. So I wondered, is it just my occipital lobe firing? You know, because my eyes are open and closed, it didn't matter. I was starting to think about all that stuff. But then I kind of got out of that thought process, and I went somewhere, like just very quickly. I was out of that like topographic map, and I was just somewhere, but I was still me. I wasn't not me. I was still me, but I was there, and I started to feel like that dandelion I described. I started to feel like I was dissolving into whatever that was, and it was awesome because I didn't hurt anymore. I didn't realize the amount of pain that I carry, and I couldn't believe what it felt like not to hurt anymore. And I just thought, I could do this. I don't need to come back. I don't need to come back. Everybody will be fine. I'll just stay here. And for my whole life, since I was a child and said my prayers, if I die before I wake, I pray the Lord my soul to take. I remember one night I'm like, oh my God, am I going to die? What does that mean? I could die in my sleep. And I started crying. And ever since then, I was like 7 years old. I was scared of what would happen when I die. And at least now I'm not scared. If that's what happens, I'm down with that. That is going to be awesome. And I feel like whenever that happens, I can say I had a good run. And wherever I'm going, whatever I'm worried about isn't going to matter. And so that was what my experience was. And then I was back in my body, and I started laughing. I thought that was awesome. That was cool. I'm not afraid anymore. Because for me, this is probably more than you wanted to ask, but procrastination is an anxiety response. And so I feel like that I have work to do, and I could do more than I have been doing. And when you're anxious about things, so the brain is hardwired to respond to unknown stimulus. Actually, Russians figured this out. They did all this research. And so like your body's like, okay, there's something new. What is it? Because it could kill you if you don't categorize it. Well, what if it's something that's like you're not able to process? Maybe you don't have the frontal lobe to process it, or maybe it's something that you'll just never know, like death. Well, that can be like this ominous thing that you can just never know. And then that can create this abject anxiety because your amygdala knows, especially I'm getting longer in the tooth every year. I'm getting closer to that finish line. I'm like, you can start to shut down and not even realize that the anxiety and the procrastination is coming from this massive unknown thing that you haven't rationalized and are at peace with. And so for me, I'm really excited to see how because this just happened like 2 weeks ago. I'm really excited to see how this plays out and to see if I can just let go of some of the anxiety and worry and just stuff that probably isn't going to matter anymore. And just while I'm here, do what I think I'm supposed to be doing because it's just correct to do so, not because I'm attached to what's going to happen when I die. And I'm not trying to transcend death and go to some place that I earned. But dying is just part of life. And what I do here is just because I believe it to be correct, not because I'm trying to be morally self-righteous. Sorry, was that like a 40-minute answer? My apologies. Yeah. Okay. Yeah.
Hello.
Hi.
Could you share your thoughts and perspectives on pregnant women taking psychedelics, micro or macro, and how that affects fetal brain development?
I would be really scared to recommend that. Obviously, I don't know. Look, if somebody did a microdose and it helped them come out of stress chemistry, one of the things with autism and ADHD and like all the spectrum issues is like they know that if there's a lot of dopamine going on in the mother during pregnancy, then that dopamine finds its home on the brain of a child. And a lot of autism spectrum disorders are there's like a dopamine hypothesis, right? That's one of the theories in child developmental disorders. I would be really inclined to not mess around with that, particularly since like if they do a full experience, that can be very stressful and there might be vomiting involved. And I would just be like, obviously I can't legally say do it anyway, but I would never advise somebody to do that. Okay. But if they are like, hey, listen, microdosing lowers my blood pressure and I have no more symptoms on my symptom curve, my acid reflux goes away, I'm no longer anxious, and I seem to have less stress chemistry. Maybe for that individual, if they work with a doctor that actually has a license to work with that, then they could do that safely. And I'd be into that if they could do that safely and they could prove that.
Yeah, it's such an interesting conversation because in the Amazon, that's part of the culture, right? And then we have the Western world and, all these Western women going, oh, it's so safe for the culture there. Why isn't it safe for me? And so it's a big conversation that's happening now, particularly in the birthing arena. These are medicine babies, and there's terminology for it. And it's I'm always so curious. Like, it's not part of my personal past, but it's a big conversation piece of, oh, this will help the development of my child because it's been a part of a different culture for so long.
I think it's an awesome discussion, but here's the deal. How different is our culture? And it's like this, it's not the substance. It's not the substance. Like for most, like I'm not an expert in like integration after psychedelic experience, but like most of like you have this psychedelic experience and then you have integration. And your integration experience is the most useful part, right? It's the information and what you do with it. So there's this kind of thing in the Western world where you take something and then you try to figure out kind of like what, we were talking about earlier. Will science like bastardize the mysticism of this whole thing? And will science like take something and then like try to patent it and then take it from the indigenous people that actually want to use it and then, use it in a way that was never intended and then expect the same result? I mean, I think it's an awesome discussion, and I think there's absolutely cultural differences, and the cultural differences make all the difference there. I don't think in the U.S. you can just do like a weekend seminar and then take the substance and then have the same result. The stakes are too high. But I love the discussion, and it would be cool if we could move a little more towards that type of supportive culture for expecting mothers.
Is heard for the first time. You used the words dopamine hypothesis.
Yeah.
So can you just speak about that? That's when the mother has too much dopamine? Because dopamine we think of as a good thing. It energizes us. It stimulates us. But you can have too much and then that can go into the baby's brain. Is that what you're implying?
Yeah, I think, this room probably understands more than any other room how powerful psilocybin can be, because it takes people that are stuck in like this dopamine type A, like very focused, laser focused, super motivated, almost anxious, obsessed mind, and then push a substance in it that totally pushes you to the serotonergic reality where like you're in bliss and you're like in joy and you're like appreciating things you never appreciated because you're so laser focused. So if a child is developing in a uterus and they're being bathed with dopamine, okay, they're going to have a plasticity towards their left brain generally. And as children, we should be born mainly right brain dominant because we're not speaking, we're not really looking at things, we're not really doing like small movements, we're doing more gross movements in utero. We're not like coordinating our hands and stuff. Our cerebellum hasn't even developed to speak. So we have no bowel or bladder control, right? We don't even use it in utero. So if you get this dopaminergic like biasing, and then when they come out and gravity hits their brain, gravity hits our cerebellum, which then projects to the midbrain, which releases dopamine. That's why like people when they have Parkinson's, what happens? They have weird gaits. They have tremor. Okay, their relationship with gravity changes. They get a stooped posture. They get camptocormic. So if you come out that way, gravity can start to reinforce that. And I don't know what the expression is. As the branch is bent, so goes the tree, or whatever that expression is. Plasticity is like that. So once that ball gets rolling, you're going to use the new iPhone and the updated iPhone, not the one over here that isn't developing at the same rate. And so what can happen is that can be the impetus for a brain asymmetry that can lead to some of these spectrum disorders. It's not about dopamine being better than serotonin. It's about balance and timing and flexibility more than it is about output.
Thank you.
Any last questions? Awesome. Well, can we get one more round of applause for Dr. Joseph P. Smith? Yeah. Oh, thank you. Yeah.